But welcome everyone, thank you. I'd like to welcome you on behalf of CRDCN to the 6th webinar in our series with the Journal of Canadian Public Policy. I'll start with acknowledging that McMaster University, the host institution for CRDCN, is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. We begin this session by giving honor and thanks to the Haudenosaunee and Anishinaabe nations and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have to this land. Before I turn it over to Mike, just to let you know, we will be using the Q&A function for asking questions, and we'll take questions from presenters after they present. So I will turn it over to Dr. Michael Veal, CPP editor, to welcome our speakers.
Hi, I'm going to do very brief introductions, each in turn. But before I do this, my own one reason I'm here myself is that I do work with the Canadian Research Data Centre Network, but I also am editor of Canadian Public Policy Analyse de Politique. And both of the articles, papers we'll see today, are based on articles that actually have come out just today in the March issue of Canadian Public Policy Analyse de Politique, and we're so pleased to have them. The first paper will be presented by Professor Minh Hu of the Department of Economics, Philosophy and Political Science at the University of British Columbia, Okanagan campus. And it is entitled Inequalities in Health Between First Nations Adults Living Off-Reserve and Non-Indigenous Adults in Canada, a Decomposition Analysis. And it's by Minh Hu, Mohammad Hajizadeh, and Amy Bombay. Please go ahead, Minh Hu.
Yeah, I'll share my screen. Thanks. Can you see my screen now? Okay. Oh, thanks everybody. Thanks for inviting us to present this our paper. First, I want to thank for the CRDCN and CPP, and also this paper we are going to present today is the inequalities in health between the First Nation adults living off reserve and non-Indigenous adults in Canada, a decomposition analysis. This paper is co-authored with Mohammad and Amy from Dalhousie University. The main objectives in this paper, we are trying to examine the health gaps between the non-Indigenous and First Nation adults. And when we're talking about the First Nation adults here in this paper, we're trying to discuss the two specific categories of the First Nations, including the Stats First Nation and the non-Stats First Nations. And also, we are trying to evaluate the both subjective and objective health outcomes, and again, for the adults living off reserve. The second approach we are trying to get is after getting the health gaps, we try to decompose the health gaps to explained and unexplained components. So basically, we are trying to better understand this issue, this health gap. So when I decompose this, that becomes two parts. First part is called the explained part, which could be the differences in the characteristics levels. Also, I may use the endowments and in the later of this paper. So basically, it's the level of their, for example, their years of education, employment status, and household income. The second part is caused by the differences in the returns. And also we call this unexplained part because this combined with the returns and also those unobservable variables from this model. And in labor economics, people always call these parties discriminations. So the main findings in this paper, we find consistency, with the other literatures. We find the Indigenous peoples, specifically the First Nation adults, they have a worse or poorer health compared to the non-Indigenous peoples in Canada. We find this reported between like 5 to 10%. Remember, this number is after controlling for some demographic, geographic, and social economic factors. So the crude gap is even larger, between 10 to 20%. So we find this gap persist and existing for both gender in the both subjective self-perceived health and also some object measures of health we find. Also, the gap we find is slightly larger for the non-Stats First Nations compared to the Stats First Nations. Also consistent with the other literatures, we find, okay, education, employment, and household income, those main social economic factors, they are positively associated with the health. And last, we find the observed characteristics, they will account for 20 to 45% of the overall health gaps for each health outcome. And again, social economic factors, they explain the majority part of that. First, give a brief introduction of the background of First Nation peoples in Canada. So First Nations, they are known as the largest group of the Indigenous peoples in Canada, together with Métis and Inuit peoples. So they have approximately 1.1 million First Nations based on the 2021 census data, out of the 1.8 total million of, about Indigenous peoples. So they grow about 10% from 2016 last census to the most recent census. Well, why First Nation peoples, is interest to discuss about their health, and because they experience very unique contemporary and also historical experiences. So this had some significant impact for their current well-being and health outcomes. For example, their stats. So based on the First Nation people, they have stats or non-stats. It all depends on if they under the Indian Act. If they registered under the Indian band, and which could be entitled the registration or not. So that means stats people, they have the registration, and the non-stats people, they don't have the registration. So this will lead some something in terms of their, for example, the benefits and their eligibilities for some special program for their wellness is totally different. Of course, First Nation people, they experience some well-known the residential school experience, and those 60 scoops and children taken away from their parents, they may have some historical and also intergeneration impact on their wellness. Also, the recent 2015 Truth and Reconciliation Commission also aroused our attention, trying to create a historical accurate record for the Indigenous and First Nation histories in Canada, and also trying to monitor taking action to address their health and also their social inequalities facing by the Indigenous peoples in Canada. Well, long and short, all of those contemporary and historical experience lead to significant differences and comparatively poor social economic stats for those First Nation peoples in Canada compared to the non-Indigenous peoples in Canada. While their health and is not good, and as the studies already found, they have a persist and worse health outcomes. They compare to the non-Indigenous Canadians. The researchers have found, there's a widened gap as time goes. Still, the gap hasn't been closed, as getting persist and widen. And also compared to the health gaps compared to the First Nation to the non-Indigenous Canadians in Canada, the gap is the largest among all the three Indigenous groups compared to the gaps of the Métis and also Inuit people. And also this health gap exists in the physical health, mental health, chronic condition, and also the other mortalities. And these health gaps could partially explained by some historical and social determinants of health. Well, there's very limited papers trying to addressing this issue. For example, studies have found there's education could explain a major proportion of the social of those health gaps between the overall Indigenous peoples compared to non-Indigenous peoples. And income could also be a very important factor, of course, including others, for example, their language speaking, and also some traditional activities, including fishing, wild fruit gathering, and also some other traditional activities. Well, the main contribution in this paper is from three aspects. So first of all, we are trying to fill the gap basically on the current existing literatures. There's a very limited numbers of the quantitative study trying to examine these health inequality issues, and specifically for the First Nation peoples. Majority of the paper combined all the Indigenous three groups together, rather than separate the First Nation peoples itself. The second is the paper trying to better understand the health gap. We're not only trying to measure, we are trying to explain the extent of these differences. So the last part, basically, we are trying to provide an introduction to the general audience about the contemporary history experience and also the current health of the First Nation peoples in Canada. And also we are trying to interpret these health gaps in terms of the differences of the so-called returns, which is the discrimination of the endowments, and also the discriminations of their returns, and also the characteristics differences, basically in terms of the endowments differences. The data we're using in this paper is only from two data sets, and one is from 2017 APS, Aboriginal People Survey. The other is a 2017 Canadian Community Health Survey. Both data sets we are using from the StatsCan RDC and the master files. So we restrict our sample to the age 18 to 65, and all of the samples, they are living off reserve. So we used the subsamples of the non-Indigenous peoples from the CCHS, and also we're using the First Nation subsample from the APS. So we're using these for a couple of reasons. So we know both APS and CCHS, they will represent their population. So CCHS is represent the overall populations in Canada, and APS represent overall Indigenous peoples in Canada living off reserves. While in the CCHS, while there's a very limited number of the Indigenous samples, and specifically there's only a couple hundred First Nations, moreover, they don't separate the First Nation to stats or non-stats First Nations, which is significantly different for their experience and health outcomes. While using the APS can give us this opportunity to using the enough sample size of the First Nation samples and also know their detailed stats and non-stats of their First Nation stats. And at the meantime, so both of the survey, they have a consistency ask questions, and they have a consistent coding of the questions, which will enable us to link those two survey together and run the regression together. So we're using the main information from the demographic variables, including the age, gender, marital status, household size. We're also using the social economic factors, including education, income, employment. We also including the geographic variables, including province, region, urban, rural, and also the main health outcomes. We're using the very well used self-perceived general and self-perceived mental health outcomes, which is recorded by the 5 points Likert scale from poor to excellent. We also picked two consistency coded like objective measures of the health outcomes. One is the diagnosed diabetes, the other is diagnosed asthma. So we start with a simple ORS linear probability model and trying to evaluate what's the health gap between the First Nations and non-Indigenous peoples in Canada, and also what factor will have impact on that. Then we're moving on the Blandner-Oaxaca decomposition to give us a better idea. How do we understand the proportion that could be explained by the endowments differences, and the other part that unexplained by the differences of the returns and the unobservable factors. To check the consistency of the variable of the two estimations, we also approached using the approach of logistic regression and the extended Blandner-Oaxaca approach to double check the consistency of the result. So the model of the equation is simple with the outcome variable y and of the two binary variable beta 1, beta 2 measure the coefficients for the two binary identity variable for the stats First Nation and non-stats First Nation, plus lambda of the set of the control variables, starting from the demographic control, geographic control, then to the social economic controls. So we have 4 different y outcome variables. So each of the health outcome variable represent a bad health outcome. So we coded poor or fair general health equals to 1, or poor or fair mental health equals to 1. If there's a diagnosed diabetes equals to 1, and if there's a diagnosed asthma equals to 1. So we repeat that estimation 4 times for each of the outcome variable, and we conduct these estimations by gender. So for the Blandner-Oaxaca decomposition, here's a very brief introduction of this. So basically, if we think the non-Indigenous peoples have differences of the health outcomes compared to the First Nation peoples. So for the non-Indigenous peoples, so their outcome is yn, that is their endowment multiplied by their returns of the characteristics. While the First Nation peoples, their outcome could be represented by the yf, which is the xf, which is their endowment multiplied by their returns of their endowments, beta f. While the differences of those two groups will be, you're taking the mean of the two, you get the xn bar, which represent the mean level of the non-Indigenous peoples of endowment multiplied by their returns minus the average level of their endowments of the First Nation peoples multiplied by their returns. So now how do we decompose the two parts? Basically, we are trying to add and subtract one component, which is a xf bar multiplied by the beta n. So it will enable us to write the overall difference into 2 parts. First part is called the explained part, and also it should the endowment difference. Basically, if both First Nation and the non-Indigenous peoples, they have the same earning returns. Okay, so all the difference only driving by the different level of the endowments. How much could be explained by this? Okay, now the remaining part will be the unexplained part, which is the returns of differences and also plus the unobservable factors. So in labor economics, we also call these discriminations. So I also want to show this briefly show this in a graph. Basically, the total difference from this level point D to point A, while the intermediate points, which is what we get from B. So basically, why we said the difference from D to B, which represented here by DC, is the endowments, because as you mentioned, if the First Nation people, they have the same returns as the non-Indigenous peoples in Canada. So the only difference that was driving by their endowment difference. How much proportion of this part, taking the overall proportion of the differences of their health gaps. Okay, so long and short is we are trying to see if the policy can target on to improve their endowment, increase their educational attainment, increase their labor outcomes. How will this improve their potential health outcomes? So this table giving the summary statistic for females, I only summarize some key outcome variables and also the socioeconomic variables. First column giving you the females summary statistics for the non-Indigenous peoples in Canada, and then second column and the last column represent the stats and non-stats First Nations. So we find for all the outcomes, both First Nation group female, they have a worse health outcomes compared to the non-Indigenous peoples in Canada. Remember this, we are representing the poor or bad health. The larger number it is, it means the worse health outcomes. Well, we find out at the meantime, the stats First Nation female and non-stats First Nation female, they both have comparatively worse household income and also comparatively worse educational attainment and also worse employment outcomes. Okay, consistent with the females, males are the same. And we found both stats First Nation and non-stats First Nation males, they have comparatively worse health outcomes and also worse socioeconomic stats. So this table represents the linear probability model result of the about general health. So again, the outcome variable still be the poor or fair health. And we found actually after column 1, it only control for the demographic and geographic variable. And column 2, after controlling all those socioeconomic variables, we found, okay, based on after controlling for the socioeconomic variables, so the still stats First Nation and the non-stats First Nation females and males, they both statistically significantly have a worse health outcomes compared to the non-Indigenous peoples. While this gap shrinked a little bit after controlling for those socioeconomic factors, which give us a sign that this could partially explain some of their health gaps. At the meantime, we find that both education, labor force attainments, and income, the higher education will improve a higher health outcome for those First Nation peoples. Same idea we found for the general mental health, still the same. So the educational attainments, employment, and also their household income, they can significantly improve the health, while this number is comparatively smaller for males compared to females. For the objective measures of the health outcomes, diabetes, we found actually the education now is expand a very minimal proportion of that, while the majority of the labor outcomes and household income still significant. The last asthma, we find the similar, while the educational attainment and household income doesn't expand that much, while they still expand the observable, they still play of observable significant impact, positive impact on the health outcomes. So this gives us a sign that, okay, the social and economic factors may play some roles for, and also may have some impact on the health outcomes. So the next step is trying to see what magnitude and what proportion does the endowment of those socioeconomic variable play for their health outcome gaps. So each bar represents the overall health gaps between, for example, here, the 100% of the overall health gaps in general health between the non-stats First Nation compared to the non-Indigenous populations in Canada. So the blue part represents the unexplained part, which is differences in returns plus the unobservable part. 75% of the overall health gaps between, in general health between non-States First Nation and the non-Indigenous population in Canada cannot be explained, right? The only explained part will be the lower part, which represented by the yellow part, which is the employment and income. 17% of the total overall health gaps in general health between non-States First Nation and non-Indigenous populations in Canada can be explained by their employment and income differences. While the education takes 5.61%, which means education explains 5.6% of the overall health gap differences, while the demographic and geographic variable explain very minimal proportion. While the negative number means actually, this explains an opposite direction. So what does this mean? This means if the non-States First Nation, they have the same demographic endowment or levels as the non-Indigenous peoples in Canada, their health gap could be bigger. So which could be explained for opposite directions. This partially explains maybe they are comparatively younger, or they have some other unobservable, demographic factors that can lead them health actually, to a worse direction if they go same as the level of the non-Indigenous peoples in Canada. So we have pretty consistency. Employment, income, education explain the majority of the proportion of the explained part. Same for the mental health. Still, the yellow part and the shadow part, employment and education. So some education might explain a smaller proportion, but income and income and employment still explain the majority part of the proportion. So for the diabetes, same we found actually the demographic variable plays like a bigger proportion for people's like the health gap between diabetes. Between the First Nation peoples and the non-Indigenous peoples in Canada. This partially because the diabetes is not only determined by the social economic factor or demographic factor, so they partially lead by the demographic factors. And also the asthma, we find actually same, income doesn't explain as much as before. There may be some other genetic or environment and some other factors that will lead to a comparatively worse asthma outcomes for the First Nation peoples in Canada compared to the non-Indigenous peoples. So to conclude, what we found is the First Nation peoples, basically they experience the poorer health than the non-Indigenous Canadians. And this is consistent for both States First Nation, non-States First Nation, both genders, and both subjective and objective measures of the health outcomes. So there's a total about 20 to 45% of the health gaps explained. And the majority of the explained part is explained by the social economic status factors. We also find the non-States First Nation, they have some comparatively worse health compared to the States First Nation, specifically in the mental health and asthma. So the limitation of this paper, and we found, we can only use in the limited information because we have to use the consistency coded and questionnaire, informations from the two surveys. And also all the health outcomes, even we call this like objective measures, still is a self-reported. So we ask them if they ever diagnosed for diabetes, diagnosed for asthma. And also Aboriginal people survey, they might undercount part of the First Nation peoples, basically when they are homeless, if they are highly mobile and for those like lower literacy peoples. So basically, actually in the real First Nation population, they might have this proportion of that. And also the last thing is about endogenality. So all those social economic factors, they are like endogenous variables. And basically there's nothing about causality can be interpreted here. So everything we're discussing is about correlation and association. Some policy implication, basically our results just warrant that some further policy attention should be to improve the health of the First Nation peoples. And also some research, maybe we're trying to specify the subgroup of the Indigenous peoples in Canada for their First Nation, Métis, and Inuit separately. And also the policy, we would suggest the policy focus on, instead of the cash transfer or the the health outcome directly, we may focus on their social economic indirect improvement of their social economic factors about educational attainment, income, and some equitable, the employment opportunities for the First Nations in Canada. And also the policy might only be sufficient, not only sufficient to just, giving the policy because of their historical and some other experience they have been experienced. So basically, we need another effective policy to work on that. And also a more holistic and multi-phased approach, maybe we should develop in the partnership with the First Nation communities and organizations to better imply those policy to them. And of course, there may be some other general universal policy, for example, Canadian Child Benefit and the other healthcare accessible healthcare benefit can be evaluated to see if the policy effectiveness between the Indigenous peoples and the First Nation peoples compared to the non-Indigenous peoples in Canada. So, okay, that's pretty much of this talk. Thanks everybody, and any comments, suggestions, welcome to send an email to me. Thank you.
Thank you very much. We don't have a lot of time for questions, but we do have a couple of minutes. So I'm looking at the Q&A to see if ones show up. But in the meantime, while we are waiting, I forget, did your data include whether the respondent had access to a regular medical care provider?
I don't have that. I don't have that information. I don't think it's consistent coded between APS and CCHS, but something worth to check. Yeah.
And the other thing I was going to think of, this plagues all studies that use income. Of course, you're only getting the current income. You have no measure of whether the person has savings or other sorts of backup in case they have an income emergency. Would that be correct?
Yeah, this is just a current household income based on their last year. So basically, APS and the CCHS, they both using the APS using the linked subsample from the census, or the CCHS using even the CRA data about their tax record. So it's about their current household income, nothing from their saving or emergency fund. Yeah.
Okay, well, thank you very much.
Thanks.
I will note a couple of things while we're getting Professor Lightman on board here, that I will notice a couple of things. I mentioned already that these papers were both published today, actually, and on the Canadian Public Policy Analyse Politique website at UT Press, University of Toronto Press. I should also note that this is our 50th volume. So the 50th volume is being celebrated, and one of the things that's going to happen is that there will be a special issue of the journal that will be published in May to commemorate the 50th volume of the journal. First issue was out in 1975. So now we turn to Professor Lightman, Professor Naomi Lightman of the Department of Sociology, Toronto Metropolitan University. Please go ahead, Professor Lightman.
Great, thank you. Everything look okay? Great. Okay, so thank you very much for inviting me to share my research today. I want to acknowledge and thank the CRDCN and Women and Gender Equality Canada, who funded this work through a research grant way back in 2021. I'll note that this research was actually delayed in part due to the pandemic, but also because of my own birth-related career interruption for my daughter. But I'm very glad that it has found a home at Canadian Public Policy, and I'd also like to thank the editors, specifically Mike Veal. So the paper is titled "The High Costs of Caring: Measuring the Prevalence and Consequences of Birth-Related Career Interruptions for Immigrant Care Workers in Canada." So I'll start with a very brief introduction that sets the context and provides the justification for this research. And given limited time today, I'm going to focus more on some key findings and policy recommendations rather than on the data and methods, as I understand there's many policymakers in the audience, but I'm of course happy to answer any questions about the data as well. So first of all, it will surprise no one here that the high costs and limited supply of quality childcare in Canada has been front and center in contemporary policy debates, notwithstanding the Liberal government's historic introduction of a national childcare program in 2022. However, at the same time, literature on the motherhood wage penalty, both in Canada and abroad, demonstrates time and again that there are high costs to mothers for being outside the labor market, caring for children. And this is particularly the case when women take extended time periods out of work and for women in lower income occupations. And in thinking about care work, which is really my main area of research interest, we know that immigrant women in particular remain overrepresented as lower wage workers in the caring industries of health and education, and that their poor working conditions in these areas were, of course, exacerbated during the pandemic. However, how and if immigrant care workers are disproportionately impacted by employment disadvantages tied to their own unpaid care for their children is something that to date has not been adequately addressed in existing Canadian quantitative scholarship. And that is where I situate my research today. So initially, I'm going to share 4 of my key findings right up front. So there'll be no surprises here. But I do think these findings are important for us as the results reinforce prior research on the intersectional nature of who provides unpaid care in Canada today and the ongoing negative consequences of this. So first of all, women, immigrants, and racialized populations were more likely to state that their main activity was either caring for children or maternity, paternity, or parental leave in Canada in 2018. And this is as compared to men, non-immigrants, and non-racialized populations. Second, between 2009 and 2018, on average, immigrant women's income was lower the year after they had a career interruption than the year prior to it, while immigrant men's income was higher. Third, immigrants who entered Canada through the Live-In Caregiver Program or the revamped Caregiver Program, both women and men, received lower average annual amounts of employment insurance income during a birth-related career interruption than immigrants who entered Canada via the family class or economic class. And as well, their ratio of employment income pre-post a birth-related career interruption was lowest. And finally, LCP or CP immigrant women, so care workers, were the most likely to have had a birth-related career interruption between 2009 and 2018. But all 3 entry classes of immigrant women were far more likely to have lower income after such a career interruption than before it. So in terms of my data and methodology, analyses were done using the microdata at the RDC with 2 data sets, the longitudinal immigration database, using the years 2009 to 2018. And I did some initial framing from the 2018 General Social Survey, which has a focus on caregiving and care receiving. And I selected the GSS because it directly asks respondents about their racialized status and about taking maternity, paternity, and parental leave for a single year. The IMDb was selected because it is, of course, ideal for longitudinal analyses and uniquely allows for accurate comparisons of different entry classes of landed immigrants over time. My focal population was immigrants aged 18 to 64, so typical working age, income, of course, adjusted to CPI. And care workers were defined as landed immigrants who entered Canada via the live-in or no longer live-in caregiver program. And my initial analyses relied on cross-sectional descriptive data, primarily providing information on which groups were most likely to take a career interruption and the ratio of pre-post-employment income after a career interruption, stratified by gender and immigrant entry class. The multivariate analyses use the IMDb longitudinal data to measure the probabilities of taking a career interruption over this time and assess the employment income trajectories of immigrant women and men who took such career interruptions, comparing results for those who entered via the caregiver program with those of immigrant workers with equivalent human capital in other entry classes over time. So one of the key things to consider is how I operationalize this concept in the IMDb of birth-related career interruptions, which was something I thought a lot about. And ultimately, it was defined and measured in terms of accessing employment insurance in a given year where an individual had a child that was less than 1 year old. And this measure is certainly imperfect, but it was the best way devised to capture the influence of maternity, paternity, and parental leaves on immigrant workers' subsequent employment income trajectories, given the administrative nature of the data. So I'm just going to provide some of the more interesting results here. So the first figure is from my initial GSS descriptive analyses. And not surprisingly, women were more than 8 times as likely as men to be caring for children or on maternity, paternity, or parental leave at 3.5% versus 0.4%. While immigrants were 1.8 times as likely to report these as their main activities compared to non-immigrants at 3.2% versus 1.8%. And the comparable proportion was at 1.5 times for racialized populations as compared to non-racialized populations. So this initial framing in the GSS suggests gendered and racialized stratification in terms of who reports that they are providing unpaid care for children and taking career interruptions in Canada as of 2018. Now, I did many descriptive analyses of the IMDb, but I'm going to skip ahead to some of the multivariate findings. So here I present a figure from the margins or relative risk ratios from one of my IMDb models. And this figure presents results measuring the probability of taking a birth-related career interruption by entry class for immigrant women only over the 10-year period examined. And the model includes as many time-stable controls as were available and relevant, such as entry class, time in the Canadian labor market, number of work permits completed prior to landing, years of schooling completed at landing, and years since landing in Canada. Using the linked tax file data, I also included time-varying controls that were measured on an annual basis, in addition to employment and EI income. And these were year, age, and number of children under age 18. And finally, controls were also included for year of landing in Canada and years since landing to address cohort effects, and a series of dummies to account as much as possible for the macro effects of the economy, so year dummies. So in this figure, the results demonstrate that the caregiver immigrant women have by far the highest probabilities of having a birth-related career interruption, so at 6.7 chances out of 100, followed by economic class immigrant women at 4.4 chances out of 100, and family class immigrant women at 3.7 chances out of 100. So controlling for human capital, personal characteristics, and cohort effects, there is evidence that LCP or CP immigrant women, these caregiver immigrant women, are most likely to take a career interruption after the birth of a child. So my next figure, and the final figure I'm going to share today, examines those immigrant women who did take a birth-related career interruption, focusing on their probability of having income that is higher, lower, or approximately the same the year after the interruption as compared to the year prior to it. And we see here that the green line, which represents those that had income 10% lower or worse, is at much higher probabilities for all three entry classes than the other two scenarios. The highest probability of having income 10% lower or worse the year after the interruption is for family class immigrant women, with a relative risk ratio suggesting a very high probability of 78 chances out of 100, followed by the caregiver immigrant women at 77 chances out of 100, with the lowest probability for immigrant women in the economic class at 75 chances out of 100. So notably, this line is pretty flat. There are not major differences across entry class, but instead a large divide across scenarios. So when we look at the red and blue lines, we see that there are probabilities below 0.2 or 20 chances out of 100 for all immigrant women of having either the same or higher income after a birth-related career interruption. So this suggests that for immigrant women in Canada, in the vast majority of cases, incomes will be lower after a birth-related career interruption, notwithstanding long-standing and critical shortages that we know exist in the caring sector in Canada. So I'm going to move along to thinking about the implications of these findings. And notably, most important legislation affecting the career earnings trajectories of immigrants operates at the provincial level. So for example, policies tied to collective bargaining and unionization, education and training, minimum wage, employment standards, and occupational health and safety are set by provincial governments. And these are certainly of critical importance to immigrant women workers, but there is, of course, wide variation across Canada. At the federal level, however, I'd suggest that concrete changes to the caregiver program and to employment insurance could help address the challenges that are highlighted in the data. And I have 4 changes I propose that would be important steps forward for immigrant women care workers. So first of all, immigrants who enter Canada via caregiver programs should be eligible to access maternity leave and workers' compensation benefits, regardless of whether their status in Canada is temporary or permanent. And encouraging better education regarding maternity and parental leave entitlements, so immigrant women know their rights, might also improve take-up rates. Second of all, the government should increase and improve programs to support the labor market integration of immigrants coming to Canada via caregiver programs. This would include assisting with transfer and recognition of foreign credentials, which has been widely identified as an area in need of support. And we know that immigrant caregivers in particular are highly overqualified in the majority of cases for the work that they're doing. This would also help immigrant care workers find work that is commensurate with their training and skills, and likely has higher pay and better maternity benefits as well. Third, further increasing federal funding for paid childcare provision would assist in alleviating the shortage of workers, improving the quality, accessibility, and affordability of paid childcare, which would assist immigrant women, as well as all women, in transitioning back to the labor market after having a baby. It would also improve pay for childcare workers who are disproportionately immigrant and racialized women. So we're really talking about the same women who are providing this childcare and also potentially needing it. And fourth, governments need to look at reforming EI and other related programs through a gender-based analysis. And this could include implementing new or more tax credits for unpaid caregiving, increasing flexibility in the definition of allowable expenses, changes to the child benefit system, increasing short-term programs to address de-skilling from extended time outside of the labor market caring for children, and suggesting regulatory changes to the definition of self-employment for income tax purposes. And I'm sure there's other suggestions from people in the audience that would also make meaningful changes. So I'm going to leave it there. The article is available now at Canadian Public Policy. And as well, I did a short commentary piece based on this article, which was published in The Conversation Canada, that might also be of interest. So thank you for your time and attention, and I'm very happy to answer any questions or and would of course appreciate thoughts or feedback.
Thank you very much. I again see that we're looking for questions in the question and answer utility, but I will ask a couple. So you combine caregivers and live-in caregivers in your analysis?
No, that was just the time. Basically, the women I was looking at, some of them came through what was called the Live-In Caregiver Program. And then in 2014, the program was just renamed the Caregiver Program. So it's in Canada, there's always only one immigration stream for caregivers. It just changed its name, and the requirement to live in was changed at the same time. And that was 2014.
Right. So I don't know very much about this, but I have some feeling that some of these people would then be working for individual families. Is that correct?
Yeah.
So if the federal government subsidized that, would that subsidy end up effectively be subsidizing that kind of care, which is probably disproportionately used by fairly high income households?
Yeah, I mean, that wouldn't be my suggestion, to subsidize in-home childcare. That's to me kind of a different question than thinking about broader childcare provision for caregivers in particular, because they're certainly not using their own living caregivers.
So a separate question, we in December published a paper by Marie Connolly and Catherine Heck about, I'm sorry if I've forgotten another author, but it was about the same issue of women having this so-called child penalty. What I found interesting about your paper is that in some sense, the results for immigrant women were even more striking, but it's also the case for non-immigrant women. They also suffer this same child penalty. Are there reforms that could be more broadly implemented that would tend to address this problem, that would not only help immigrant women, but would also help non-immigrant women?
Yeah, absolutely. I mean, as you say, this motherhood wage penalty is true across the board, but it does disproportionately impact women in lower income occupations who are disproportionately immigrant and racialized women. I believe that finding accessible and affordable and high quality childcare is the single best way to try and address this labor market gap. Of course, things like having flexible workplaces and, hybrid offices and having better provisions for caregiving, whether it's for your children or for other dependents like elderly parents or other people in your family, would all make a difference. But I do believe that childcare is like the single biggest barrier that women face upon attempting to re-enter the labor market after taking time out. And I also think that, women take longer times out of the labor market when they don't have childcare, and that's a major indicator of how well they do when they re-enter.
We have a question from Megan. I have a quick question for Dr. Lightman. does she control for job categories in her analyses?
Yeah, so obviously a major downfall of using administrative data is that we don't have occupational information, right? We have kind of intended occupation at landing, but we don't have job categories. So we kind of compromise in terms of having an amazing, essentially a census of immigrants, but then we only are able to use the information that we tick off in our tax file or the landing file that immigrants fill out when they come to Canada. So no.
Another question. This is all very interesting given the recent move of childcare in Alberta from the Ministry of Child and Family Services to the Ministry of Jobs, Economy and Trade. Any thoughts on this shift?
Yeah, I mean, it's a really good question. I tend to think it's not a good thing, but we do know that certainly the caregiver program has always been framed as a policy that explicitly aims to fill a gap in care provision in the labor market. And at the same time, so too has Canada's system of maternity and paternity leave, historically and presently, I would say, been framed as primarily an employment policy. So I think from the perspective of governments, both of these have always been labor market policies, but the implications, of course, fall on women and families. And I think, at least given the current government in Alberta, my inclination would be that this is not a positive move in terms of improving outcomes for low-income immigrant and racialized women. But would be curious to hear other perspectives on that.
So I do have a question for Dr. Hu, but I think the best thing to do would be to finish off the questions for a while, and I'll just fit in a question for Dr. Hu before we conclude. So we're going to stay with Professor Lightman. I was going to follow up the question that I asked because you quite correctly, I think, pointed out that childcare is probably one of the big factors in this motherhood penalty that has been discussed. And then I guess I was just going to point out, really for comment on your part, there's a kind of irony here because I don't know if you know the work of Beth Dewey, but Beth Dewey has pointed out that for the coming childcare programs, we don't have nearly enough early childhood educators, like really not enough. And you were talking about a potential source in terms of people who have immigrated to Canada to do childcare. They might be a potential source for that, and it turns out that they are not continuing on in employment to the degree that we would expect. So I was wondering if you'd comment on my comment.
Yeah, I mean, I absolutely agree that, the critical shortage of ECs and like childcare assistants is a crucial, is perhaps the key element of the childcare shortage. But that's all, in my opinion, in terms of kind of addressing that from a policy perspective, it's all about wages and employment conditions. There's very high turnover rates among ECEs. My area of interest is kind of low wage care workers, which includes like healthcare workers and education workers. And there's very common issues across the board. It's overwhelmingly women, overwhelmingly immigrant and racialized women who do this work. And they tend to not stay in these jobs because it's, they can barely make ends meet. And we don't value these jobs. So I think it's about how society, we have to put our money where our mouth is. If we care about having quality childcare for the future generations, we have to pay the workers well. So to me, in that way, it's quite obvious what needs to be done. It's just a matter of prioritizing that.
So thank you very much. I am going to turn this question to Min Hu, and then I will have a few summary remarks. So why didn't you, I think they're asking you, Min Hu, consider cultural factors in health outcomes is the question.
Yeah, so it's a good question. Yeah, actually, we're thinking about so the cultural factor will be mainly about their language speaking and traditions. Well, the main thing is we have to find the consistently coded questions and from both Aboriginal People Survey and CCHS. And I believe the only question we have consistency is the language speak. Well, if they can answer the survey, that means they speak English and French. So it's kind of like bizarre to control for that. So we really hope can control for if they speak Indigenous language or some other language, while in the CCHS don't have this type of question. Yeah, thank you.
All right. So it remains to thank our two speakers. This is a really good session, really interesting. Again, the articles have been published today in the journal, and I hope some people will check them out. But thank you both for your excellent presentations, and thank you also to the people who came to listen and participate in the conversation. Thanks very much.
Thank you.
Thank you.